Thanks very much, John, and I appreciate the invitation to engage with this group. A really interesting talk so far, and I have lived in the policy world much of my career, and so I love all the frameworks that everybody's putting up. I'm also a pretty practical guy and live with the issues in rural Alberta in healthcare of not being able to deliver the care that we need, and many of you have spoken about that today. So I'm going to focus my comments a little bit differently than the rest of the speakers. I think my job today is to maybe prick your thinking a little bit. I love the language of mental models of care that Ray and others have talked about. I think our mental models are wrong often, and that's why we haven't gotten further in rural healthcare. So I'm going to just stimulate a little bit of thinking around some of that if I can. Hopefully I'll be successful. So I don't know if any of you locally recognize this. This is the first hospital in Grand Prairie, 1912, and it was also the residence, the home of one of the local religious leaders. We've come a long way from then. I drove from the airport by the very modern looking and large Grand Prairie Hospital, which does some pretty amazing things. This is a picture of the population of Alberta. There's many formats for this. You're all well aware of this kind of a picture, and this shows some of the challenges we have in trying to deliver care in a constrained system economically that's trying to do some groundbreaking, world-leading things throughout the province, and we do a lot of those things nationally and provincially and locally, and there are huge segments of our area in Alberta and the population, which we've heard 20% or so is in the definition of rural, that really don't necessarily have access to some of those things. Is that right? Is it wrong? And how ought we set priorities around some of that? So I'm going to muse a little bit about physician workforce, because I do a fair amount of work with physician workforce, did in the early 90s until the early aughts, nationally and provincially, and then took a long break from it and have worked a little bit again with the Alberta Medical Association around some current challenges. And it's distressing for me to hear the same language today that we were using 30 years ago. And we actually did some really, I think, groundbreaking and important work around the physician workforce. There's dismal physician workforce statistics currently, but just in the last 6 months, the trends are slowly reversing. And I'm encouraged by that. We're a long, long ways from where we need to be. Some of the credit to this goes to a number of the agencies that we've collected to work together: Alberta Government, Alberta Health Services, Alberta Health, our post-secondary education system, the Alberta Medical Association, the Health Quality Council of Alberta, which is now branded as Health Quality Alberta, many other organizations. The compensation models have made a difference, and it takes a few years to catch up from where the negative sentiment has really strongly been in Alberta amongst residents and people graduating, that this is not the place to come. It's changing, and it's changing dramatically. And for the first time, I've heard in some specialty areas like radiation oncology, everyone we train is staying. We have the money and the resources applied enough so that we have a sufficiency of that staff group currently, and anesthesia is improving. Family medicine is actually improving, and when you look at the statistics of the number of family medicines who are actually taking patients in Alberta, it's increased by like 400% or some number like that. And some of that's in rural, more of it is in urban for sure. But so those are really encouraging things. Compensation models that have improved for primary care is making a difference. We don't think that the compensation models directly address some of the unique things about rural health care for physicians. We are slow to the table. Other provinces have beat us to the punch, but we're catching up now. And that's encouraging. Our compensation for residents is improving. And all those things are helping people to come back to Alberta. So I'm encouraged, but we've got a long, long way to go. Now, rural Alberta has uncommonly high reliance on internationally trained physicians. And there is response by all our health agencies, including government, and this is directly related to policy. So I think I'll just find some numbers that I have. The Canadian Medical Protective Association, who is a physicians insurer, gathers about 96% of Canadian physicians. So it's about 115,000 members they have. So it's the largest single organization that can use statistics about its membership. In 2024, 28% of the membership had graduated from medical schools outside of Canada. And in 2000, that was 23%, so it's increasing. About 12% of the membership in the CMP are from Alberta. Family medicine, the growth in family medicine percentage in Canada has been 26% over the last number of years, 34% in Alberta. So there's an increased proportionate number of family medicine graduates coming to Alberta. In Alberta, the number of internationally trained medical graduates is consistently higher than the national number by about 5%. So, for example, about 32% currently of Alberta physicians are internationally trained graduates. In family medicine, the difference is actually 15%. So nationally, 31% of family doctors are IMGs. In Alberta, 46% of family doctors are IMGs. So nothing good or bad about that. In fact, I tend to think it's actually pretty good because the training environment for IMGs often, and especially from places like Zimbabwe, South Africa, are fantastic for rural practice. Having been one, I was always in awe of the training rigor that my colleagues from some of those countries had, and the competence that they had and confidence that they had to handle really difficult challenges in rural Alberta. So it's a good thing, but there are some really important policy levers that all the agencies have had to pull to make that actually work appropriately. So the college has changed some of their rules around the dates and the timing for when people can apply for residencies, for instance, from overseas to Alberta. The establishment of the two new schools in Grand Prairie and Lethbridge for training family physicians and physicians has just made a sea change in the attitude difference, I think, for where we are in Alberta. And so congratulations go to our government and to our health department and for advanced education, and certainly to the universities for actually taking that step. I'll talk a little bit about that later in a mental model change that I think we might need to make. It's going to make a huge difference to attract and retain people, but also to focus a different level of education and care opportunity for our rural residents because of those things directly. It's just an amazing change that has occurred. The universities now training specifically physician assistants and in Calgary and nurse practitioners in Edmonton will make a difference as well as we move really more directly into team-based care, not only in the care environment, but in the education environment as well. The Alberta Practice Readiness Assessments that the college here has done are 5 years ahead of anywhere else in the country. And it's made a substantial difference in getting people into the community to provide service, but also to provide the confidence to the population that, yes, these people are competent and they're safe and they're who we want to have. I do a bit of work with the Alberta Association of Gerontology recently, and we've had a series of presentations over the last few months on the challenges for the workforce. And I was struck by, because my thinking is always about, well, the emerge department and the hospitals and community clinics and family doctors out in rural Alberta, the challenge in staffing for assisted living, long-term care, continuing care in rural environments especially. So we talked earlier about having communities of people that know each other and that want to stay because they actually develop a community there. The education and ongoing training, the multiple jobs that people have because the compensation isn't very good, and the distances between those jobs in rural Alberta is a huge challenge for folks. The language barriers and the aging workforce. So there's some really good documented evidence now that the workforce in rural Alberta for assisted living long-term care is also aging. And what are we going to do about that? So really, really important things. The distance and safety is a unique thing in rural. Compensation is a unique thing, and the training environment and the opportunity to have certificates and gain knowledge where people are actually working are things that we're all working on, hopefully successfully soon, but it is a huge challenge. But I also want to muse a little bit about opportunity, and here's where I want to prick your brains a little bit. So I would say that old thinking about workforce and healthcare delivery will make us old. And we are still today we're talking about it, I talk about it all the time, and we have this mental model in our head of a physician, and now maybe with a bit of a team around that physician, being available to do everything as generalists in a rural community. And we struggle to get those people there. We struggle to get them to stay there, to be part of that community. And maybe that isn't the right thing that we should be thinking of doing. So there is an imperative to care for people, ideally, using our collective resources. And the refocused implementation of our imperative, I think, suggests that we need to think differently about this. So we've organized healthcare around professionals, the diseases, usually an organ-specific disease, and broad interventional services. And so we think, now, how can we make that better? What are we struggling about? And forgive the hockey analogy, but I know it's on everybody's minds right now. You have this process of a certain kind of a defensive system on your hockey team, and you finally figure out how to put it into place. Like we're finally figuring out how to do all these things we've talked about today about different policy, different implementation. And then suddenly the other team has moved their offensive strategy, and our old trap defensive mode isn't going to work anymore. And in today's healthcare environment and today's population, what they demand of us and what we can offer through technology, maybe we need to be thinking differently. And so here's what all this work has resulted in. This is from Manitoba, not from Alberta, but we're seeing this every day I read, which different hospital in rural Alberta is closed for the weekend. And that for the community is devastating, as you all know. And we're trying to change that. I know you all are, we all are, but we're still doing the same old things that we did before. So maybe we should organize our healthcare delivery around when patients might seek something. What does that look like? So it's very different for the person who's a member of an assisted living facility who needs 24-hour care than a patient who's coming in because they've had an accident on their ATV or a farming accident or an industrial accident or whatever. What are they actually seeking? What teams or components of teams can best assist that particular kind of resident of rural Alberta or rural Canada in their healthcare needs? So it's probably not the individual well-trained physician who does rounds every day in hospital and does a few shifts in Emerge and does a clinic and rounds in the long-term care facility and delivers some babies and all the rest. What technology can assist? And even though you've all said today you had challenges with the technology, even simple communication technology as you drove out here to a pretty big place, I learned from the taxi driver today it's 70,000 people in Grand Prairie now. It's a pretty big place. Technology can assist, and the technology is changing really rapidly. I'll talk about that in a minute. And then do all our resources need to always be directly applied, or can they be appropriately remote or virtual? And in Canada, we've all talked about this, we have studies and plans to plan, and everything takes a glacial amount of years to get done. And when the pandemic hit, within 2 or 3 months, we were doing virtual care almost exclusively. So when a crisis can hit, we can mobilize our resources and our thinking pretty effectively. So an example I want to give from years ago, but is very applicable today. And I use this deliberately because in honor of a friend and colleague and teacher of mine and Jill's, Greg Powell, who's an emergency physician, and Rob Abernathy, his emergency physician colleague, who started with 3 Lions Club members from, I think from Calgary, STARS, Air Ambulance, which has now been in operation for 40 years. And people think that, well, this is something the government did. It isn't. And they struggled to get funding in the early years. They've now done 63,000 missions. That's a lot of rural Albertans, rural Manitobans, rural Saskatchewanites' lives saved, and a lot of staff members in healthcare who were helped by this very rapid expert response. That is an amazing thing that community built itself. And that's dramatic thinking. No one thought it could be done or should be done at the time. That's the kind of thinking we need today to make a difference. So maybe instead of thinking about the one physician and a team around that physician or that clinic, and it might be centered around a nurse practitioner or others, doing everything, we should be thinking about the different parts of healthcare access that we need. So we need wellness, preventive, and public health services to keep us well and healthy, hopefully. Although that's a bit artificial, we now know that if the average age of life is 81.5 years or whatever, and I know it varies a bit in different parts of the country and rural versus urban, but we live in the age of chronicity. And most people have chronic illnesses, and they spend the last now 10 to 12 years of their lives with multiple chronic conditions. And we need to care for those people. We need to keep them as well as we can. They still need, even if they've been very well for all their lives, they still need our services in an interventional way eventually. Then there's diagnostic services. And there's treatment, acute intervention, and rehab. There's chronic disease management and end-of-life care. And you could argue maybe end-of-life care should be in the treatment, acute intervention, and rehab bucket, but I'll say that it's separate. So each of those might be amenable to a whole different way that we deliver care in rural Alberta. And you might not need that physician and healthcare team to do each one of these on a specific arranged or emergency visit. Maybe we need to be thinking completely differently about how we organize health services. And part of the reason I say that is because of things like the Apple Watch and many other bits of technology. So I heard a great presentation the other day by somebody who many of you probably know, Dr. Zaina Kayat, who is a health futurist from the University of Toronto. She's really well known, has great presentations, and I've got some great quotes from her as well. I probably won't say it, but she really focuses on this notion that all this great work we're doing on interoperability of healthcare data and information, important work. We've spent billions on it. Still can't get that stuff electronically at my hospice or at many other places in rural Alberta, but we've spent billions on it. But it's a smidgen of the health data that is available out there. And there's when you look at the graphs of what all that information from the health system is versus all the information that there is on things like the Apple Watch and many other bits of technology now, 5 years from now, the way that we access healthcare is going to be different. And so my pitch is we should be spending 5% or some amount of our resources and our thinking time thinking about where the puck's going to be, not where it is now. So we finally, after 30 or 40 years, we're doing some great things that we should have done 30 or 40 years ago, but we're still focusing them on the health system of today and yesterday, not the health system of tomorrow. And it will be different, what people need, what they access, and where they access it. So just a bit back to end-of-life care. So this is our country hospice outside of Okotoks where I live. So it's the first rural, freestanding, nonprofit end-of-life care facility. It's beautiful. It's got great care. We're stimulating now a number of other places in Alberta to have similar things. Many of you have talked. We had the resources to build it, so we built it from the community. No government help to build it, to design it. No system help either to fund it. Now some effort to get some operational funding increase because we're funded to about 50% of operational needs. But some of you talked about the difference between rural communities and rural communities, and it's really true. So I worked with another group, the Olds and District Hospice Society, and they didn't have the resources to actually build their own freestanding hospice, and maybe not the population to support it. We draw 50% of our patients from Calgary, urban. And so we're full all the time, and with great care ratings by the patients and families and the staff. So Olds didn't have the resources to build one, so they do have some beds in one of their facilities that are designated as end-of-life care beds, but they contemplated buying instead an Airstream trailer or like a Winnebago RV, and bringing it out with their staff to a farmer or rancher's family who was dying and wanted to stay at their home, and actually setting it up on their property for the 2 or 3 weeks that they'd need, as a place for the staff to be able to collect, to have the medicines that they need available, to converse with each other, and for family members maybe to have a bit of a break from being inside the home where their loved one is dying. So an innovative solution for a different kind of rural opportunity. This is the way that I think we likely need to be thinking. So priority setting in ethics is a really important thing. Many of you talked about the ethics imperatives of equity. And I think we need to look at that in a little bit more deep way. And in priority setting, we're always talking about both the macro priority setting, as say a government who says, look, if the healthcare enterprise is $24 billion in Alberta, how do we allocate those resources in an appropriate way? But we also have to look at local priority setting. What matters for this particular community and their needs? If it's a First Nations community who has a particular kind of health challenge, and we've got some in the South that have just done a fantastic job in their healthcare delivery system to make a difference for the needs of their population, and are doing that locally. Should we be saying in Alberta, we need world-class some places, or good enough all places? And I'm not going to say what I think the answer is, but it is a question we need to ask ourselves. Should there be a minimum standard set for everyone in our province first, before we fund the third cardiac operation for, my cohort of over 65-year-old males? We should not accept the status quo. Government's role is really important, but there's also community and individuals' roles. And in priority setting and allocation and the issue of equity and equitable care and opportunity within the sector of rural health, we need to think really carefully about how we're going to allocate these resources. I would argue that we absolutely should be saying as a people of the province, and this should be the same anywhere in Canada, that we will not accept that individuals, even if they are remote, cannot get very basic services that are required. But we have to mobilize people differently, systems differently, and technology differently to make that happen. Thank you.